I'm back. More hepatic stuff. So now let's do cirrhosis. Cirrhosis is a disease of the liver. It's not like hepatitis. It's not a virus. It is a destruction of the liver, often caused by alcohol. Alcohol is the number one reason, and basically what it is the replacement of good normal liver tissue with scarring, the different kinds of cirrhosis. One is alcoholic cirrhosis. That's the most common. It's caused by over drinking too much, and prior to that starting, like the people that drink a lot can start getting what's called like a fatty liver, and their liver can get enlarged and have a lot of fat deposits. And the liver has a remarkable ability to repair itself. It's one of the few organs that can regenerate itself. So when you're doing a liver transplant, you can just take part of a living liver and transplant it into somebody else, and the residual liver that's left there will regrow. It's one of the few internal organs that does that. But it gets to a point of no return. So when somebody is drinking a lot and they just keep drinking and they can't get that under control, then it's irreversible. Post-necrotic cirrhosis is usually a result of somebody who's had a really bad bout of viral hepatitis, and that can also occur like secondary to an infection, like somebody who's had hepatitis, like metabolic liver disease, exposure to certain toxic drugs and stuff. They can develop this post-necrotic cirrhosis, people that have exposure to certain chemicals, certain industrial agents and things like that can develop post-necrotic cirrhosis, meaning something else, like those things I just mentioned, like an infection or viral hepatitis, things like that, can cause the liver to start necrosing and lead to cirrhosis. Or biliary cirrhosis is where scarring and breakdown occurs around the bile ducts, and then that can lead to biliary cirrhosis, oftentimes caused by chronic biliary obstruction. But that one's not very common. So those are the different types of cirrhosis, and the symptoms, the clinical manifestations are very similar to hepatitis. The patient will have fatigue, jaundice, hepatomegaly, meaning a large liver. You'll be able to palpate it, but sometimes. Sometimes at first their symptoms are pretty vague, but then it's fairly debilitating. So look at the chart 4911 on the top of page 1367, how to assess for cirrhosis. The other thing with cirrhosis is they can start developing this thing called caput medusae, which is engorged varicose veins right around the umbilicus. And the reason it's called caput medusae, you remember that Greek goddess who had like the snakes coming out of her head like that? That's what those veins look like. I want you to Google image what caput medusae looks like, and that's a classic sign. And basically it's just portal hypertension. So I remember when I was telling you about hepatitis, those veins come around and they get very tortuous, and it's like that collateral circulation that has high pressure, and it can lead to that. That's a telltale sign of hepatic disease. Okay, so cirrhosis, similar to hepatitis, can cause portal obstruction, can cause ascites, It can lead to infections, peritonitis, especially the ascites that is, if there's a lot of fluid in the peritoneal cavity, it can lead to peritonitis, which can be life-threatening. The GI varices, I already told you about that, like caput medusae, distended blood vessels throughout the GI tract. You're going to see some esophageal varices with people that have cirrhosis. They have a lot of edema. They have a lot of vitamin deficiencies. They have anemias. And then when you start seeing the mental deterioration, that's usually a late sign of cirrhotic disease. There are some medications that they use for cirrhosis, but most of them are used to treat the symptoms of problems related to cirrhosis. So for example, like the GI bleeding and stuff, and the portal hypertension, they use some medications to reduce blood pressure, medications to reduce like the H2 antagonist to decrease gastric distress. Kind of read through the medical management. There's a bunch of drugs in there that they use for patients who are on who have cirrhosis. So again, there's not really a cure. There's just management. You want to try to manage the patient so that they can have the best quality of life as possible. You really want to improve their nutritional status because they're not hungry. They won't be hungry. They have a lot of anorexia. They have a lot of dyspepsia. They have diarrhea and constipation. You're going to expect those things. You're going to treat those things as a nurse. You don't need to run and announce, oh my word, my patient with cirrhosis doesn't feel like eating. You know they don't want to eat. So, you do things like bring them foods that they, are interested in, small, frequent meals rather than a large meal. Give them plenty of rest. You want to give them good vitamins. Vitamin A, C, vitamin K, the B complexes. The thing about liver patients is because your liver has a lot to do with your clotting factors. So you have to watch your patient's PTT and INR because those can get delayed. Your patient is prone to bleeding, not only because they have clotting factor problems, but also because they have portal hypertension and esophageal varices that bleed. And so once those do bleed, if they have their clotting factors are all out of whack, then they are even more prone to hemorrhaging. So you have to be cautious with that. They have bile salts that get deposited, so you need to provide good skin care for them. Now, there are certain things that you do need to notify the physician about, and the most classic one is bleeding and hemorrhage. So similar to what I told you about the esophageal varices, if you suspect that your patient is having bleeding from the portal system or esophageal varices or GI varices, watch for things like increasing heart rate, dropping blood pressure. You need to notify somebody immediately because you're going to have to thrombose those arteries that are bleeding. Hepatic encephalopathy. This is, your deteriorating mental status, dementia. You need to watch your patients who have liver problems. You need to watch their mental status very closely and report those kind of changes quickly because you want to prevent that from getting out of control. So if you notice your patient with liver disease is having neuro changes, you need to notify somebody or give something that's already ordered to help reduce hepatic encephalopathies. You be very careful with fluid. You have to watch their eyes and nose very carefully because they can become very edematous. And pulmonary compromise becomes a problem because the liver sits right here, and if the liver is full and swollen and they're getting ascites and that's full and swollen, it can push up on the pulmonary system. So sitting the patient up in a Fowler's or semi Fowler's position, giving diuretic agents like Lasix and stuff to try to, and mannitol to pull off as much fluid as you can. You want to restrict how much fluid they're ingesting. Make sure that your IVs aren't running at crazy high rates. You know, and good coughing and deep breathing. You want to try to maintain as good of a pulmonary functioning as you can. You know, hopefully the patients are going to be able to go home and manage this stuff at home, so they need to learn all of these techniques. You need to teach them how to manage this, what to watch for when they go home. Okay. I'll just finish the rest of this chapter up really quick. I think, yeah, let me just finish this up really quick. Cancer of the liver. Anytime you hear the word neoplastic, that refers to a malignancy, and anti-neoplastic is the cancer drugs, and anti-neoplastic drugs will suppress the immune system, which is why when your patients who have cancer and they're on chemotherapy, which is an anti-neoplastic drug, they drop their white blood cells, because chemotherapy will attack fast-growing cells. White blood cells are fast-growing, so it knocks down their white blood cells, but it also suppresses their immune system, which is why their patients who are on chemotherapy and anti-neoplastic drugs, because of the suppressed immune system, are also at high risk for infection. Liver cancer, it can be either primary or metastatic. A lot of tumors love to mets to the liver because so much blood supply goes through the liver. So if you've got a malignancy in the colon or the breast, those two things, they love to mets to the liver, and so some of those cancer cells will break off from one spot and float up through the liver, and then that is a secondary malignancy. It's metastatic colon cancer in the liver, metastatic breast cancer in the liver, something like that. You can also have primary liver cancer. If you have just one mass in the liver, they can remove a lobe. You can live without part of your liver. The problem is, and that's the best case scenario, you don't want to have like a shotgun effect of tumors. So if you have a shotgun effect, you can't take all the lobes out. You have to leave some lobes in. So best case scenario is to have a primary liver cancer isolated to one lobe, and they can go in and surgically remove that part of the liver. If not, if it's more of that shotgun look, or if it's metastatic, then usually it's palliative care. They can do radiation right to the liver. When I was working in GI cancer at U of M, I worked with a physician there who had developed a technique where there's a little reservoir of chemotherapy, and they put it right under the skin, kind of like a diabetic insulin dispenser. It was like that, and they put it right under the skin, and they would fill this thing with the chemotherapy, and they put it right into the portal artery, and so it would deliver chemotherapy right to the liver. And so they had some pretty good success with that. So when you suspect that a patient has a liver cancer, they have a little bit of different clinical symptoms, clinical manifestations. They usually have like just sort of a dull ache in the right upper quadrant. It might even radiate to the back. Weight loss, loss of strength, loss of appetite. Weight loss is a classic cancer sign in almost all cancers, by the way. And they could also start having like an enlarged liver. They can develop jaundice. They can develop ascites, especially if it's starting to compress those the portal ducts that are supposed to be draining the bile and things like that. So that's kind of it with liver cancers. And I'll talk about transplants. In some patients who have shot their liver, and this is usually because of hepatitis or cirrhosis, if they meet the qualifications, they can go on the liver transplant list. This becomes a little bit controversial and an ethical dilemma sometimes, because oftentimes people who have either hepatitis or cirrhosis have done something that society deems not okay. And so then, you know, the question becomes, is it okay to give that person a liver? For example, if a patient has acquired hepatitis B or C because of IV drug abuse or high-risk sexual behavior, or they've developed cirrhosis because they spent their whole life drinking, should they be the one to get these precious, valuable resources of a new liver? Or should we give it to somebody who, you know, might have, you know, have not high-risk acquisition? Like cirrhosis can also be caused, I forgot to mention this, by being overweight. Really grossly morbidly obese people can develop fatty livers, and then that fatty liver can turn into cirrhosis. So, you know, in that case, let's say that person lost a bunch of weight and they're healthy enough for a transplant, you know, should that person get the transplant over somebody who has, you know, had just drunk themselves? And what is the likelihood that they're not going to drink after they get the new liver? So there are some controversies about it. Livers don't transplant quite as well as kidneys. The rejection rate is a little bit higher. There are some, and unlike kidneys, they have to remove the liver in order to make space for the new liver to go in. And there are a million immunosuppressant drugs that patients with liver transplants have to be on. I would like you to know some of these immunosuppressant agents. Neoral, Prograf, Imuran, Cellcept. These are usually a cocktail of drugs that they give patients. Usually they're on more than one. There's usually about 3 of them that they put them on to try to get the patient to not reject the organ. And they're on those kind of medications their whole life. And they can reject just like they can have, you know, hyperacute rejection, which is right away, or acute, or they can reject the organ, you know, throughout their lifetime. So you do have to watch for signs and symptoms of that. Okay. So it shows you there, shows you how to do, like, down on page 1382, how they do liver transplants. And those are huge surgeries that take a while, but it's pretty cool. Okay, and liver abscesses, you don't need to know about that. That's not super common. So, okay, so that's it for chapter 49, and then we will talk about, in chapter 50, we're going to talk a little bit about cholelithiasis and lap choles. I think that's about it. Just kind of the gallbladder diseases. Oh, and pancreas. Gallbladder and pancreas. Okay, I'll do that one next.